What is SonderMind able to do based on its size that a small fragmented practice wouldn't be able to do?
The primary unique advantage that SonderMind has. Now, as it pertains to just our sort of pure scale, one of the things that we have, smaller companies don't have as broad a footprint or have a few hundred providers, maybe in one or two regions. It provides us the ability to address the patient need more appropriately. So again, in mental health, it's somewhat difficult to discern what's the real need and what's the diagnosis going in, and therefore how do you kind of get the right provider associated? Because we partner very deeply with in many markets with health systems.
Welcome to the next episode of Scale Community's Technology and Innovation in Healthcare podcast. I'm joined today by CEO and co-founder of SonderMind, Mark Frank. Mark, welcome to the podcast.
Thanks, Jason. It's great to be part of this.
So why don't we begin, as we usually do, with just a quick introduction to SonderMind, what the company offers in the market and the footprint.
Yeah, happy to do that. So SonderMind is the highest quality scaled mental health provider organization in the country. We offer in-person and virtual care for all issues engaging with outpatient mental health care. So think therapy, medication management delivered by master's level providers, PhD, and MD and Psych NP on the medication management side. And then we are a full stack tech operator. So we actually built our own technology solution to drive all of that. So it's our very, very functional EHR with a lot of tools and features for the providers, as well as digital applications directly for the patient. So think everything ranging from meditations and resonant breathing to sounds and sleep tunes to improve either your sleep or your focus, as well as even science-backed brain games that improve things like emotional bias, memory, cognition, et cetera.
You mentioned virtual plus in-person. I'm curious what the mix of those two are.
Yeah, the mix.
Also, just which geographies are you focused on covering?
So we're available in all 50 states, and we accept all major forms of third-party insurance. And so that's everything from commercial insurance to Medicare, Medicare Advantage, others are government forms of insurance as well. And the mix between in-person and virtual is about 80-20 virtual in-person. The mix also varies somewhat widely across states. For example, in Georgia or in Texas or in Colorado, we have closer to that, probably 15 to 20 to 25% in-person capability. And in some other states like Pacific Northwest or in Florida, it's currently still predominantly virtual. So maybe it's only about 5 to 10% in person. And those change as we continue to penetrate inside of the state.
And on the in-person, is that all outpatient care, or are you also doing any inpatient residential care?
All outpatient care and all, I'd say all sort of non-programmatic outpatient care. So what we are not doing yet is intensive outpatient therapy or partial hospitalization. Those are still in the outpatient care bucket, but those are things that we are not doing.
So primarily or predominantly virtual care, behavioral health. It sounds like broadly focused in terms of conditions. Are there particular conditions that you're focused on, or general?
It really spans the entire spectrum. So everything from very low acuity, stress, anxiety, low level depression to very severe instances of those things. So, we come in with severe depression, things like that. And as well as serious mental illness, substance abuse disorder, again, when the care is appropriately delivered in an outpatient setting. So often that means, discharging from an inpatient facility into a community provider that is a SonderMind provider. And then all demographics. So we treat adolescents and children all the way to senior citizens and everybody in between, as well as family care, whether it's couples or child-parent dynamics, things like that. And then one of our real claims to fame is the speed at which we get people both into care, but also to a better outcome. And so we measure all at a baseline, and then throughout the care journey, we measure how you're progressing, right? And so as many, the measurement tools in mental health are, I'd say very subjective. It's just to use at least a factual term, and in my opinion, not not where we need to be. So I think there's a lot of push for us to improve our measurement tools. As an example, we typically get somebody who comes in with severe depression or severe anxiety as measured by PHQ-9 or GAD-7 to a subclinical level, absent medication, in on average, 6 to 8 sessions, and they may stay with a provider for another, 2 or 3 sessions to get to a stabilized point. And that's one of the things we're working on, is how do we, engage more with the insurance plans, with value-based care programs, and taking on, slightly more capitated risk.
So when you think about 80% virtual, that's a business that didn't exist or couldn't have existed, rewind maybe 6 years ago, pre-COVID. So virtual care has been broadly commercialized since that point in time, I would say. And we've seen a lot of new entrants in the virtual care space within behavioral health and in other specialties as well. And so the models vary. Some are based on full-time providers, others are based on sort of renting partial capacity from providers. Some are 100% virtual with no in-person. Some are direct to patient, some are B2B. So maybe a good way to introduce SonderMind would be to put SonderMind in the context of that broader landscape. How do you compare versus other players in the market, and what is the business model of SonderMind?
Yeah, so we are, broadly speaking, you could characterize us as an MSO. I'd say we're probably somewhere in the middle of, you've got the employed sort of like pure group practice setting, maybe it's 20, 30, 100 employed providers in a group in a market, all the way to sort of the more marketplacey type organizations out there that are really kind of like taking a cut and ultimately doing sort of rev cycle management and some billing and maybe a little bit of patient matching. We're functionally probably closer to the former, functionally closer to the group practice setting, where therapists join us. Now, they are generally speaking 1099. That's a construct, I think, in mental health that's a little different than a lot of other areas of healthcare, where these providers are more often than not operating in sort of a part-time capacity by choice, right? They're not, if they want to be in an employed setting, then they are moving into that setting. But many therapists especially go into the field for 2 primary reasons. One, it's a calling, right? It's like they want to help people and like they're givers. And then 2, it's a lifestyle choice as much as it is a career choice. It affords them the ability to sort of have a sine wave of activity on a multi-year basis, right? Like, hey, I want to be full-time and then I want to go into private practice. But even intra, right, where you say a lot of providers are also home, our caregivers or homemakers. And maybe in the summertime, they sort of pare their practice down a little bit because the kids are home from school and there's vacations and things like that. So we really wanted to meet the provider where they were coming from. And so that's some of the reasons why we created the model that we did. As it pertains to virtual versus in person, and you mentioned even like it wouldn't really existed as in the way it does today. I founded the company back in 2015, 2016 timeframe. It had a really kind of focused real estate aspect to it as well. I subsequently separated in late 2017, and my co-founder runs the real estate piece, which you can think of it as like a we work with therapists kind of offering, different company. SonderMind, up until literally, February of 2020, was 100% or 99% in-person care delivery. Now, we had our goal and our strategy was always to be the highest quality hybrid provider. Because again, pre-COVID, it was like, all right, we see that the telehealth is coming, and there were some other companies out there who were doing virtual care, but it was really more like text therapy. That was sort of the bulk of what some of the more tech-focused operators were doing out there at the time in mental health. And there was a smattering of video where they were doing sessions, but it was mostly a lot of like text therapy, like a consumer subscription model. And so we were building out. We had launched even in February of 2020. We had already launched our text therapy feature and had been building for about 6 months our video capabilities. And we were planning to launch that in May of 2020. Well, this little pandemic thing happened and required us to, we have to sort of pull that up. And so by April of 2020, 100% of our volume pretty much was virtual. And, I think for us that created some tailwinds. Certainly from a provider recruiting and onboarding standpoint, it made it a little bit easier because we could do that more scalably. It also created some tailwinds because the payers and, broadly speaking, kind of like the healthcare system became more focused on the needs that we had identified as being pervasive in terms of mental health needs that patient had. So access was able to be increased, but it also created some headwinds for us as well. And one of them was that we had always planned to be this sort of hybrid operator, and it forced us into being this purely virtual one for a period of time. And now we're sort of like saying, how can we live in this primarily virtual care world, but continue to move in the direction that is, we believe that it makes sense to be able to visit a provider virtually as needed, but if you need to see them in person, that you can do that as well.
So 5 to 6 years into commercializing and broadly deploying virtual care, how mature is the model today? How scalable is virtual health? On the one hand, it's incredibly scalable. You're in 50 states. If you were in a physical footprint only model, that would be much harder to achieve. On the other hand, I'm wondering about things like quality. I'm wondering about things like patients who do ultimately need in-person care. Where do you see us today from a virtual care market perspective? And what are your thoughts on the model 5 to 6 years in?
Yeah, I think one, I think it's been tremendous in terms of improving access to care, so specifically in mental health, right? I mean, it's just because it's episodic and because you often need to engage with the provider, in one episode of care, 5, 10, 15 sessions, right? For 45 minutes or an hour, spread out maybe over 3 to 5, 6 months. It just like, even if you say it's enabled access because providers are now more willing to engage and can take insurance and things like that because of companies like us. There's the other piece of like, you've removed some friction points for a patient to just get in, right? Like the thought of driving to an office 10 times over a 3 or 4 month period creates some level of friction versus a portion of those or all of them can be done in the comfort of your home or in your office or whatever the case may be. So that's helped improve access to care, period, full stop. And I don't think it's going away. So if there's like, to the extent that we wanted to rewind the clock, us or the industry, I don't think that that's going to happen. As it pertains to quality, I think it's a really interesting question because when you think about in mental health, again, different than in physical health. In mental health, what's unique about mental health, or one of the things that's unique is you actually have to get into care before you diagnose, right? Like if you think about and that's not true in most cases, right? Like in most cases, you walk into the urgent care and you go, my arm hurts, right? And if they start poking around in your stomach, it's like, no, wrong part of the body. Like I know what hurts, right? My arm. And they're like, let's x-ray it and it's broken and let's go fix it. And maybe then it requires physical therapy and requires some other things for you to do. But it's very clear about like where you ail. Whereas in mental health, it'd be like walking to the urgent care and going, I hurt. And the doctor or the nurse says, well, what hurts? I don't know. You tell me. It's like, well, can you point me in the right direction, patient? Like, no, that's your job, doctor. Like, tell me where I hurt. And it's like, well, I need some help. And so that's mental health, right? Like you go in and you're like, I don't know. Something's wrong. And maybe you rely on some self-diagnosis, but that may or may not be accurate. So the quality question in mental health is one that I think we have to take a step back and go, how are we really measuring quality? And then to answer your question of how is it measured in what setting is an appropriate question. But I think the first question should be, how do we ascertain quality, right? Which actually has to start with how do we ascertain a diagnosis? And the reality is our minds are far and away the most complex organ in our body, right? Our brain is like, we know so little about how this really works. And so what we do know is that our emotional state, our mental health is a function of a variety of inputs, right? And these inputs are made up in our own head, right? Like some of them are just like what we think. They're environmental, right? So I mean environmental, like climate, right? Because we want to be literally, there's a thing called seasonal affective disorder, right? Like, where like if you don't see the sun for a period of time, you start getting depressed. So I mean, that's truly environmental. But environmentally, even in like the people you interact with, was there traffic on the way to work or not? What did you eat? How did you sleep? Do you, like all these things affect your mental state at any given point in time. And so the one thing we have today that we didn't have 10 years ago, 20 years ago, 30 years ago is the ability to measure and actually receive a lot of these inputs, right? Like people have have Aura rings and they have Apple Watches and they have, other things that are actually collecting biometric information, and they're tracking, and they're now engaging with AI. And so you start to collect this. This is the thesis for our full tech stack, and the SonderMind app has a lot of tools that allow you to engage and then share that with your provider. So all that gets to a point where you go, okay, now we can start to better measure what ails you, right? Before you even see your therapist for the first time, we can say, let's get you into care and into a provider that is a good match based on all these different inputs, but also that empowers the provider with information so that that provider can actually say, oh, I know what Mark is dealing with before the first time I ever see him for a session, and maybe actually even, not actually, but even actually like on the 5th or 10th session, right? Well, I know what happened between the 9th and the 10th session because he's been engaging with the app and engaging with the tools. So the way we measure quality and think about it is actually easier to do it in a virtual care setting. Now, why is that? Because we've built, AI session note generation tool and things like that, which is opt-in from the provider and the patient. So as you get that data and as you start making recommendations, as the provider makes recommendations to the patient, it's empowered by the AI. There's a co-pilot for the provider where in the session, the provider co-pilot is sort of helping guide. And then following the session, it becomes a co-pilot for both the patient care journey and for the provider. And all that is actually better delivered in a virtual care setting from a quality standpoint, because it can help identify signals from a voice inflection standpoint that maybe you wouldn't have as readily available in an in-person setting.
So initial triage, ongoing navigation, ongoing management sound like those are things that are distinctly better for virtual care than in-person care. Is that a fair summary?
I think if when coupled with the other tools to engage. So absent, like Sonder, we've built a variety of digital tools. I mean, everybody can download the SonderMind app for free at this point. We've not moved yet into a freemium model. But it's widely available, and it has a variety of tools that you would often pay for from other apps, right? Everything from those sort of digital interventions that I mentioned to, like an AI assisted journaling portion where you can just engage with it. And then you can summarize that. And if you're in active therapy, you can share that with your provider. So when you take those things and then you share it, then yes, it helps from a triage.
Yeah, I mean, I think there's two layers to the question. One is, what is the role of virtual care? And then the other is, should that virtual care be standalone? I'm a virtual care company, or integrated into a broader ecosystem, either clinics or facilities, which we'll come back to that point in a second. But I think on the first point of, how do we use virtual care as a tool? It reminds me of a conversation I recently had with a women's health CEO who has a virtual care business, and similar things. There's a lot of navigation, there's a lot of education, and there's a need for upfront access. And so virtual care has some unique attributes that expand supply to create quick access, increase convenience to allow for education to occur, have benefits in terms of remote monitoring for ongoing navigation, ongoing management. So now let's talk about the role of, given those benefits, let's talk about the role of virtual health in the care ecosystem. So if I'm a patient, I don't have to wait for an appointment, or I have to wait a lot less for an appointment with SonderMind. So yay. And I can go through that initial diagnosis and triage. And it sounds like there's probably two tracks. Track number one is, I have a certain profile or condition type that I can stay with SonderMind virtually and continue to get treatment and care from my provider. And track number two is, that's not the case. I need some in-person care. Is that right? And if so, and that track B, how does the handoff work from the virtual care to in-person? Let's assume it's a SonderMind clinic, and then let's assume it's not a SonderMind.
Yeah, so maybe one adjustment to that is that what we've endeavored to do is not separate this idea of there's like a virtual care provider and there's an in-person care provider. Now, I should note, again, a majority of our care is delivered virtually, and that is because a majority of the providers generally are not doing in-person care. At least under our umbrella, we have 13,000 therapists and psychologists and psych NPs and psychiatrists in total. So when you sort of say, okay, let's assume that it's 20%, it's slightly more than that, but let's say 20% of them are offering in-person capabilities, and the other 80% are like, no, I'd prefer to deliver the care that I'm delivering from the home or from a virtual office, something like that. We are we are shifting, I think, as a society and certainly as an industry, where there are more and more providers who are going back to being able to deliver some level of in-person care. But our thesis from day one was always that it shouldn't be, all right, you have an in-person provider or you have a virtual provider. It shouldn't be an either or, it should be an and, right? That your provider, we only match patients to providers and engage with providers that are in their market, right? At a minimum, they're in their state, and generally speaking, they're in their metro area. So as that happens, a patient can say, I prefer in person, right? Or maybe because of a severity, we say it might be better for in person, but it's generally speaking not going to be exclusively in person, right? It might be
the right model is same provider, but it sounds like the provider's day is just changing. Instead
right.
of being 100% in person, now that provider is spending half their day, 3/4 of their day, sounds like 80% of their day seeing patients virtually, and then they have appointments for the patients that need the in-person care.
Right. And maybe the patients who need the in-person care don't need it exclusively either. It might not be the patient type is an in-person patient versus a virtual, but rather this next session needs to be. So not dissimilar from what we've seen in the work economy, right? Like a lot of companies that have gone back to the office are often not 5 days a week back in the office. Now, look, a hospital has nurses and doctors that are there 5 days, 7 days a week, right? But a lot of corporate jobs, that's not the case, right? You might go into any Fortune 500 or Russell 2000 office, whereas 6 years ago, pretty much the whole company was going to be at one of their, like in their locale at one of the offices on any given day, whether it's Monday or it's Friday or Wednesday. Now, I would argue you're probably at any company going to see a higher attendance rate in office on Wednesday than you are on Monday. Generally speaking, that's just, anecdotal. And so I think it's the same thing. We as a society have started to integrate, all right, what are the things that we're doing in person? What are the things we're doing virtually? And saying, how can we blend those things? Because there are certain meetings that are much better to be done in person, right? Just in a work environment. And in the same way, there are certain therapy sessions that are much better to be done in person. And there are others that are better to be done virtually, right? And I think that's the balance of like saying, how do you empower providers to actually make those clinical decisions to say, what's the best way to get to the outcome that we're looking for with this patient?
So I think just in summary, at least in the outpatient ecosystem, and we'll come back to inpatient in a second, in the outpatient ecosystem, it sounds like virtual health should be an embedded part of care delivery. And those that get it right will have sort of the ability to transition from virtual to in-person.
Yeah, back and forth. That's right.
So now let's talk about scale.
Mm-hmm.
We ask this question a lot of different specialties. What does SonderMind do, and what is SonderMind able to do based on its size that a small fragmented practice wouldn't be able to do? Because I think just purely seeing patients, through a camera virtually, a small practice probably could do. And maybe that's wrong. So feel free to correct that if it's wrong. But what is it that SonderMind is able to do to improve care based on its size, investment wherewithal?
Yeah, I think there's two things. So one, before we get into size of footprint and number of providers and session volume, it's what we've done that's different than basically every other company out there is the investment we made over the past 7 years in technology and continued investment. So this has been organic investment, building our own technology platforms. This has been doing some acquisitions where we've bought some companies that have, we bought MindStrong and then the technology assets and the IP and the product team and the technology team around that. And they raised nearly 150 million. And all that went into investment to improve treatment planning capabilities with an input of all the data that would come from a variety of sources from a patient standpoint. So we've incorporated that into our care delivery. So that's something that, large companies that are sort of similar to us from a scale of footprint providers have not done and don't have the capability to do. And certainly a small practice with 100 providers is not even going to have any idea. They're buying things off the shelf, right? So that, and the fact that all these things are integrated, right? So this is where it's a SonderMind patient application, it's a SonderMind EHR platform, it's SonderMind AI models that are integrating and engaging directly with the patient, directly with the provider, and even in the care delivery itself, right, within the session. All that then creates a data advantage for us because those models and the ability to make those recommendations around treatment plans, around what interventions to use, can empower the providers in a way that other companies can't do. And then you layer on, okay, now the scale that we have creates that creates its own loop of improvement, right? Because now you have more and more providers that are improving those data models and making the tie between, hey, when you do this, it leads to this outcome more quickly. So that's I would say the primary unique advantage that SonderMind has. Now, as it pertains to just our sort of pure scale, one of the things that we have, if you sort of remove all that, which would be silly for us to not speak about, but just taking it at sort of a broader lens to say, okay, other companies that do have a similar footprint of providers, right? What do all of us have an advantage of as it pertains to maybe smaller companies that don't have as broad a footprint or have a few hundred providers maybe in one or two regions? It provides us the ability to address the patient need more appropriately. Mm-hmm. So again, in mental health, it's somewhat difficult to discern what's the real need and what's the diagnosis going in, and therefore how do you kind of get the right provider associated. In the rest of physical health medical community, where you have residencies and you have specific types of doctors, right? You have a urologist or a neurologist or a pulmonologist or a cardiologist, right? And those all focus on different parts of the body, right? And then you have other doctors who are focused on different diseases, right? You have oncologists and endocrinologists, and so you have other doctors who are focused on the disease state. Well, in mental health, you got one, right? You have a psychiatrist. If you're talking about a prescribing doctor, okay, fine, you can split it between youth and adult, but those are the two specialties basically. Or if you're in the master's level or PhD level, it's actually wide open. You can treat, there's not like a special license type for treating depression that's different than the special license type for treating ADHD that's different than the one for treating trauma. Right? It's all one license type. But the reality is most of these providers do focus on specific issues. They do focus on specific demographics. And whether those demographics are based on age, based on gender, based on race, based on even faith, things like that, you have this kind of limiting factor when you have a smaller footprint of providers that you actually can't get the right provider to the right patient as easily as you can when you have thousands and thousands of providers like we do.
So, and also virtual, I imagine. So are patients, periodically calling into another provider or providers coordinating and teaming up to take advantage of the virtual care platform to get the right complement of providers to treat that specific patient?
Yeah. So what we do is, and I can't speak to other companies that are sort of in the space, how they're doing, we really say, let's make it frictionless. Let's make it super easy for, if it's not the right fit, that either the provider or the patient can say, you know what, I've now done a couple sessions, I have a better idea of what issue I'm dealing with, and I don't think this provider is the best suited one for me. Or the provider is often saying, hey, I'm not the best suited one. And then the provider sometimes is sort of rematching that patient to another provider because they can search within and say, hey, who are the functional experts in the SonderMind ecosystem in this specific geography that I can, get them to. And then it's an easy transfer. The same on the patient side can say, hey, I want to rematch with a different provider. So that's just across sort of the provider, the mental provider ecosystem. But one thing to note is we partner very deeply with, in many markets, with health systems as the primary behavioral health partner for health systems. A lot of health systems and hospitals and large scale primary care organizations, one of the top issues that their patient population is facing is mental health, right? And whether they're prescribing medication, in which case they can, but they often say, well, I need to do some curbside consultation with a psychiatrist, or they're saying, yeah, I have in my practice of 5 docs, 5 primary care physicians and a couple NPs, I might have 1 or 2 LCSWs that are there because I've got some value-based care model in place with the plan, or I'm an ACO or whatever the case may be, and therefore there's some incentives in place for me to manage this part of the patient need. They quickly find that those LCSWs are operating more as traffic control or triage, right? And so they're doing an initial assessment and then going, but I don't have the bandwidth as an employed LCSW at a practice that's, if I have 5 PCPs in the doc, it's maybe a patient population of 8 to 10,000, right, annually. I can't, 1 or 2 LCSWs is not going to be able to treat that population, right? If 10 to 15 to 20% of them need therapeutic care in that year, maybe it's even only 10 sessions, the numbers just don't work out. You would need 10 to 15, you need probably a 3 to 1 or a 5 to 1 ratio of like therapist to primary care doctor in order to sort of meet the needs. So then we come in, we say, hey, we can engage, we can link in with your EHR, we can provide you the easy button from a referral standpoint, but also provide you that care continuity to say, we're going to communicate and say, yeah, Mark got into care, Mark's seen this provider 3 times, here's some change in the diagnosis, we feed this information back into you. And so that's the other part of the collaboration piece that I think is really important to note when you talk about mental health and how it intersects with physical health.
Yeah, I mean, it's a great point, and it gets, I was going to start to go down the inpatient route, but it brings up another question related to that before I get to inpatient sort of facility-based care. What portion of your business is either direct to patient or practice to practice referral streams versus what I think you're referencing of more B2B partnerships, where SonderMind is a dedicated behavioral health provider to a hospital, and you're really collaborating and partnering to cover their behavioral health needs so that the hospital can focus on what it needs to focus on.
Yeah, it's a pretty wide mix. So we have direct to patient, direct to consumer marketing we do and advertising, things like that. Clearly, from a cost standpoint, that's one of the more expensive ways to acquire patients and get them into care. We work directly with the payers, not just as a contracted and network provider organization and provider group, but also in terms of various partnerships and the ways that we can ensure that the plan is getting their members access to care. So, I mentioned the SonderMind app. With some plans, we've started to deliver the SonderMind app directly to the entire member population, right? Because it's like, hey, here's this tool that can actually help to meet some of your needs, you as a patient, you as a member, before you're in need of care. Right, like you can, it's preventative to a certain degree, and so that's another sort of funnel or area for us. And then a lot of these partnerships, as you just mentioned, these B2B partnerships, I would say primarily with health systems and other care organizations. So that could be not on the mental health side, but also on the mental health side. You started going into the inpatient sort of realm, and I think if you mean inpatient on the behavioral health side, if you think about it, well, the inpatient facility providers, right, that are doing 30-day stays or partial hospitalization or even intensive outpatient, which most of them do all of the above, they need to graduate those patients, certainly from when they're in beds to when they discharge them, they need to get them out. And they can't actually discharge them until they've been connected and have at least a first appointment set with a community care provider. And their staff is not set up, generally speaking, to engage. So we do partner with those organizations as well.
And so with those non-hospital facility-based organizations, so eating recovery-based facility-based organizations, substance abuse facility-based organizations, psychiatric mental health facility-based organization, how's the collaboration going? Because what we've seen is there's been a lot of change in that market, I think driven by a number of different factors. Part reimbursement, part the proliferation of virtual health. And so it's changed people's desire and need to come to facilities, at least on the margin. And then part some new drugs that have come in for example, the GLPs in the eating recovery space.
Yeah, for sure.
And so it's a space that's gone through a lot of change, and some have adapted to that. Some have built their own telehealth platforms. Some have struggled to adapt to the change. How do you see the collaboration going on, and what are your thoughts on the integrated model, sort of those facility-based organizations building out their own virtual care versus partnering with someone like SonderMind and having SonderMind handle the virtual care?
Yeah, I think there's 2 aims that these partnerships usually are seeking to hit. One is, hey, as I mentioned, we as an in-person, like let's say you take that inpatient facility, mental health, like let's say substance use facility, right? Our average patient is going to be with us for 30 days or 60 days, and we need a discharge partner. Even if we have created some level of virtual care, that's typically not going to be enough to sort of meet the need to keep them, to discharge them, to get them out of the facility and then the right care setting. And from a true care model standpoint, there's a benefit to then going, let me shift from the intensive care that was part of that inpatient experience to something that's more part of my normal routine. There's a benefit. It's similar to, like, generally speaking, when you have a surgery, the hospital might have physical therapy in the hospital, but more often, even if they own the physical therapy delivery mechanism, it might be in a non-hospital sort of outpatient office, MOB or something like that, right? That's closer to home. That's a little bit more, and that's a surgery is doesn't have as much stigma associated, doesn't have as much sort of general, you don't really think about like surgery as like recidivism. It's more of like you might have a readmission for something that goes wrong with the surgery, but generally if you have your knee fixed, it's probably going to be fixed, especially if you do the physical therapy properly. So in mental health, there's that dynamic where you want to get them out. In those cases, the partnerships are working really well when that's the primary aim. The other aim that is often a primary aim from the partners is, hey, we want you to be a really important lead generation tool for us, right? Because again, from their standpoint too, they're going, well, we have to take people out of the facility and put them into the community setting, but then we got to fill that bed, right? We got to get the heads in the beds. And so in that scenario, they're looking to us going, hey, can you help identify? And the challenge is that oftentimes when somebody needs to be admitted into an inpatient facility for mental health, their therapist may not even, sometimes, yes, the therapist is recommending them into it, but oftentimes the reason the therapy is not working or they're continuing to degrade or their acuity is getting worse is because they're not being fully transparent with their provider, right? Because actually, like, they're not embracing some of the things and they're not saying, like, let's, again, follow down the path of substance abuse. They might be telling the provider that they haven't been drinking, but they are, right? And then all of a sudden they sort of like fall into a worse pattern, and at some point somebody else needs to intervene. So our ability to sort of fill the beds is not as efficient. So now it's like those providers those facilities that are building some of these things out themselves. I think the challenge that they've found in talking to some of them is that when they have their own outpatient sort of paradigm, virtual or not, but let's say virtual, it helps on that first aim, but not any better or maybe a little worse than how we would help in sort of getting the discharged patients into care, because from their standpoint, it's a less profitable line of business. And it's not their core focus, right? Their core focus is the inpatient facility. And then, so the real reason they're doing is a capture tool, it's a top of funnel, basically, how do we get patients in? And they're seeing the same thing, right? It's like, well, this patient, this virtual outpatient group that we've created isn't really creating the kind of ROI from a demand gen standpoint for us. So yeah. I think long-term it probably doesn't. I think what happens is that they have to do two things. One, there probably needs to be more strategic level partnership between some of those organizations that are operating at scale, those inpatient facilities, with companies like us that are operating at scale, and say, how do we do this, across a variety of ways to identify patients? Again, we can identify patients who might be in need of higher level of care, not just from what's happening from the therapist and relying on the therapist to say, hey, let's flag somebody, but because of the digital tools and the ways that we can engage in the day-to-day operations, the day-to-day life of the patient, that provides an opportunity for us to then be more embedded into the referral flow to those inpatient facilities. And then two, and this has happened more slowly than I would like to see personally, just as somebody who's trying to see a lot of change in the mental health space, is I think that we will need to see more and more value-based arrangements with these inpatient facilities where they are further incentivized to reduce recidivism and to get people better and keep them better. And that's starting to happen. But as it happens more and more, and as the insurance companies and the plans start to really push incentives around kind of outcomes, then we move away from a fee for service. Then all of a sudden it's like, actually, no, success becomes not keeping them in the facility and keeping them in the bed or getting more and more in. It's how do we get them in, treat them, and get them out and keep them in a healthy lifestyle, right?
I was going to ask about the alignment of incentives in these partnerships. So do you have any value-based care financial reimbursement models in place today? And if so, is it capitated? Is it risk-based? Is it performance incentive, quality outcomes?
We have a number with the plans right now, and all of them, I'm trying to think if there's any nuance to my statement here before I say it. I'm pretty sure, unless something's changed in the last week that I don't know about, all of them are generally performance-based, so there's not really any downside risk. We actually are trying to push a little more of accepting downside risk because, again, our model is such that we've demonstrated the ability to get people to a better outcome in a shorter period of time, which when you think about it from a pure economic standpoint, right, just as a business, not as a care providing business, just as a business, we go, hey, if we're paying the same on average to acquire a patient, so if our customer acquisition cost is the same as our competitors, but we're delivering care in a way that gets them to an outcome that is better in a shorter period of time or equal in a shorter period of time, let's say, well, then economically, we're actually disadvantaged. Right? There's a disincentive for us to do that. because as a fee-for-service provider, generally, like there's value-based programs and stuff like that. But if we get somebody to that high, that really positive outcome in 8 to 10 sessions, and the competitor next door gets them there in 14 to 16 sessions, and we pay the same amount for acquiring the patient on average, well, guess what, right? Their economics are better than ours.
Right.
But that's not, as a industry, I think broadly as a healthcare industry, that's not where we want to go, right? Like we don't want to go into that's where we've been a lot. That's why we put in place models like, the Affordable Care Act and ACOs and things like that, where there are value-based care models and where we can say, let's start to pay for. So we are more and more convicted in how we can move the needle by taking on potentially some risk, because we believe that we're able to generate, a better or equal outcome in a shorter period of time than a lot of the other companies in the space.
But it sounds like most of that discussion around value-based care and reimbursement innovation is between SonderMind and the payer, more so than SonderMind and a strategic partner like a hospital or another facility-based organization.
Right, because the hospital and the other facility-based organizations, they're even further from that from a mental health standpoint, right? Now, again, the facility-based ones, I think, should be doing it, or the plans, I should say, should be doing it, but a lot of the facility-based organizations do rely on the revolving door a little bit, unfortunately. And that's not like a function of of poor quality. That's just a function of the patient population is a very difficult one to treat, right? If somebody, again, I'll follow down the substance abuse disorder path, but there's a lot of others. If somebody has this, it's difficult, right? It's difficult. You could get them better, but there is a high degree of recidivism with that patient population, with the best providing, organizations out there. So I think appropriately, understandably, that some of those organizations are less willing to take on the downside risk, right? Because they're like, our model works right now in a fee-for-service setting. So I think it's going to be incumbent upon the plans to really start engaging more in that way. And that's where I do believe there's opportunities for us to collectively partner, right? To say, hey, we take a holistic approach. It's not how do we incentivize the facility-based organization with a risk-based contract. Well, they're going to go, wait a second, how do I do that? If you're giving me a population, I'm kind of I can't really manage the risk in the way that I deliver care. I just treat people who come in the door and who I admit. But from our standpoint, it's like we can deploy, a digital application to millions of people, right? That actually starts to intervene and starts to diagnose before we even talk about getting them into a care provision. And then you get into care with a mental health provider from SonderMind. Again, whether it's a prescriber or it's a therapist or a psychologist, and you say, well, we can start to manage that care and still have the wraparound of the technology offering, and then begin to understand more how to identify those patients who need to get into that higher level of care. That it has to be, in my mind, a holistic approach.
I want to end on one final topic. So, behavioral health gets a lot of attention for various reasons, but I think it sort of boils down into cost plus access, which is similar to many other specialties. And I'm wondering if there are, on the topic of cost and access, if there are any 80-20 sort of rules about what's driving cost in the market and what's driving the greatest barriers to access in the market.
Yeah.
MSK, musculoskeletal, you might see joint replacements driving a large portion of the cost, for example. Are there particular conditions or circumstances for, ER visits that were avoidable, things of that nature that are driving outsized portion of cost? Uninsured population, homeless population, or is it less 80-20 and more spread across?
It's pretty spread. I would say it depends on the view from which you're taking, right? So, but let me hit the access question first, because if you look today versus if you look 6 years ago, the access to care, while not solved, it's orders of magnitude better in mental health than what it was. So when I started SonderMind, it was very, very difficult and very rare for a mental health provider in an outpatient setting to take commercial insurance. Interestingly, there was actually a big footprint who were part of these organizations that, were federally qualified health centers or agencies that were focused on the Medicaid population. So you actually had it wasn't enough access, but you had a lot of access for the Medicaid population. And then you had a lot of access for the population that was willing and able to pay out of pocket, right? Hey, it's okay. I can pay $150 a session or $200 a session to my practice because I'm, living in, the Upper East Side or something like that, right? But for the majority of the U.S. population, that's not the case, right? You can't, like, that's not a budget item that fits into anybody's family budget when the household income in the U.S. is $70,000 to $80,000 a year. So people rely on their healthcare insurance, specifically commercial and Medicare Advantage, for the provision of care, right? That's just how our healthcare system works in the United States. And it was very difficult for that middle 80%, not Medicaid, not sort of high income, able to pay out of pocket to access care. That I would say, has largely been solved. So now let me answer sort of the by solving that, what has changed from a cost standpoint? And this isn't the question you're asking about, like what's driving the cost from a plan, but I'll get to that. So what's changed is now we've seen a doubling of the number of insurance claims that are being paid in the last 5 years by plans for mental health care. That's a lot, like that. Wow. And often more than doubling in ticket dollar value standpoint. Just purely claim volume has doubled for commercial plans from 2019 to 2023. That's the data that I have. The number of people who are accessing care in the United States, accessing mental health care, went from roughly 35 to 40 million a year between 2017 to early 2020 to now between 2022 and 2024, 60 million, 55 to 60 million. So that's increased by 50%. So more people are accessing care than ever before, which is excellent, which is great. The problem is we haven't seen a similar decrease in the reported issues. Mm-hmm. So we're giving people more care, but it's not actually getting them better. The outcomes aren't really there. Now, I'm saying that these are all industry numbers. We are seeing the outcomes there because the model, I think that the reason we're not seeing the outcomes broadly across the industry, because the model is broken, right? Like, hey, just go see a therapist and talk for 10 sessions and then you're going to be better, isn't really going to work. You have to have a wraparound technology solution that actually enables the care to be delivered more effectively, the diagnosis to be delivered, the things I talked about earlier in the podcast. So all that, I think, is where we've seen costs start to balloon, and you've seen the plans start to talk about it. We've heard on the earnings calls that the insurance plans are starting to say, we have to focus on some of the how we manage the cost, the increasing costs of mental health care associated with what outcomes are we getting from it. Now, what we have seen is that mental health is at a minimum, a correlated diagnosis and oftentimes a causal diagnosis for a number of things. You mentioned one of them, emergency room admission, right? The number of people, so the correlation is exceedingly high of people who are in the emergency room with a mental health diagnosis. And getting them out of the emergency room actually often requires, when they have been identified with a mental health diagnosis, even upon intake, you need then a mental health consult to get them out and make sure that they're able to get into care when they leave the emergency department. That's a huge driver of cost for two reasons. One, if they're holding space in the ED and there's somebody else who comes in and they can't get them admitted because they're holding space, then what do you do? And then you have adverse outcomes, right? Two is back to the sort of causal point. Yes, there are scenarios where these sort of not a silly example, but an expensive one that is non-life threatening. Somebody, like Mark in 10 years is stressed, and maybe I've been seeing a cardiologist, and I start to get shortness of breath, and I start to say, "Oh my gosh, I'm having a heart attack," and so I call 911. They send the ambulance, and I go to the emergency room. And lo and behold, is it a heart attack? No, it's a panic attack. Why? Because maybe my kids are out of the house and I'm, empty nest or whatever, right? But I have a panic attack that I think is a heart attack. Well, guess what? That just cost the system tens of thousands of dollars, right? And it prevented somebody else from using that space, and it sent an ambulance out when it shouldn't have, et cetera, et cetera. Well, can that have been prevented by engaging with Mark in a mental health care way? Yes, right? Absolutely. Now, there's a lot of other things that are more serious in nature, right? That kind of coincide with social determinants of health and things like that. So there's a lot of blending of this, but we do know that treating mental health conditions on a population level does reduce cost. What I believe that the plans are trying to suss out right now is how do we incentivize companies like SonderMind to keep doing the care delivery in a way that is unique and can actually engage with a broader population to further bend the cost curve down while not having cost balloon on the care delivery itself, right? Of the provision of outpatient care delivery.
So it's not, on the access side, we've got more people insured today. We've got more providers that are in network, and we've got virtual care. So there's three pieces that are driving improved access. On the cost side, in some ways, we're at an inflection point, and we've got more claims, we've got more visits and more utilization of services, and we've got a TBD question on outcomes. And so you've actually got more expense now than you have had historically, notwithstanding that SonderMind itself at a micro level is getting better outcomes. I'm wondering how successful SonderMind has been at delivering care to underserved populations, whether it's rural markets, whether it's lower income markets. Is that a market that you've been able to deliver what sounds like a really strong foundation for getting better outcomes? Have you been able to deploy that to that market, or is that still tough to access? And so maybe in the macro sense, we've got more access, but to specific populations, we haven't really improved access the way that we need to.
We definitely have. Now, I'll say what we haven't done as a business strategy is, at least from a very focused, high priority business strategy, is go and target like the Medicaid population. Two reasons for that, just if you're wondering, or if the audience is wondering why. One is we don't have the full suite of wraparound services that you would often find at a mental facility, right? Like you walk into the mental facility, and if you're a really, low income or underserved population, maybe even homeless, like the first thing they're doing before they can address your mental health needs is like, we got to make sure you've got food to eat. We got to make sure you've got a place to sleep tonight. We've got to maybe get you a shower. Let's try to get you some job assistance and find you some work, right? Like those are core needs.
Go beyond care.
Their needs go beyond care, right? And we don't offer that. And so that's one reason why we've not targeted the Medicaid population. The other is a little bit more of a, let's see how this continues to shake out. There are companies out there that are doing that, meaning they are delivering care in the way that we are, but they're focusing on the Medicaid population. In my mind, one of the risks of that on a micro level, on a local basis, is that those organizations that are providing all those wraparound services, that person who walks in, that homeless person who needs all those things, they provide all those. Well, that's generally from government funding and from donations and things like that, right? And they can't really bill that much for it. In some cases they can. I know there's a lot, like Food for Health and things like there's initiatives that are changing that. But generally speaking, a lot of those things are not paid for via a CPT code, let's say, right? But what is paid for by a CPT code is that therapy session that the do or the care coordination that the LCSW might do. So that's how they get paid. They also have people walk in the door who don't have all those needs, right? But they're still underserved population. Maybe they're engaging with Medicaid, but they have all those needs met, and they really are there for service in the way that we would deliver service. Well, guess what? These are nonprofits, right? So I'll say, but those are like the most profitable patients for those nonprofits, right? So if my fear is that if we or others who are doing kind of a model like we are and are focusing on the Medicaid population, but aren't providing these wraparound services, are we actually siphoning off the most profitable patient population of those nonprofits? And really, like, with good intention, this isn't like intent, right? But the unintended consequence might be, gosh, now I've made this really vital part of the community less able to deliver care to that most underserved population, because the slightly better off but still underserved population I am now treating, and I've removed that volume from that organization. That's just a fear of mine that I'm waiting to see how it's impacted other communities, because I don't want to be unintentionally a part of the problem.
Makes sense. Understood. Mark, I really want to thank you for the time. I really enjoyed the conversation.
Yeah, thanks, Jason. This is great.